Hello and welcome to today's Better Care Playbook webinar on how the program of all-inclusive care for the elderly can meet the needs of dually eligible individuals in rural communities, which is made possible through the support of the Seven Foundation Collaborative. My name is Nancy Archibald, and I am the Associate Director for Medicare and Medicaid Integration at the Center for Healthcare Strategies. Next slide, please. Okay, before we get started, I'd like to go over a few logistics. To eliminate background noise, audio lines are being muted during today's event. There will be a question and answer session following today's presentations, and you may submit a question online at any time by clicking the Q&A icon located at the bottom of your screen. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, please complete the brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you will take a moment to answer those evaluation questions. Next slide. And next slide. Okay. We'll begin with a brief introduction to the Program of All-Inclusive Care for the Elderly, or PACE, and also to dually eligible populations. Our first speaker will provide a PACE provider's perspective on running a PACE organization in rural Kansas. Then we'll hear from state officials in Pennsylvania about their efforts to make PACE available across the state, including in its most rural counties. Then we'll follow that with our Q&A session. We encourage the audience to submit questions as our speakers are presenting. We'll have about 20 minutes at the end to answer your questions, but please don't wait to click submit on those. Next slide, please. For those of you who may not be familiar, the Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. Every month, the Playbook summarizes new journal articles, evaluations, and implementation tools. The Playbook also develops resources like this webinar designed to help translate evidence and research into practice. You can explore the Playbook, including a number of PACE-related resources, at bettercareplaybook.org. And I'm dropping a link now into the chat for a recent PACE-related resource. Next slide, please. The Playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. Next slide. The PACE model of care was created in San Francisco back in the 1970s, and Congress later authorized PACE as a demonstration program. Then the Balanced Budget Act of 1997 granted PACE permanent status under Medicare and gave state Medicaid agencies the option of including PACE as a Medicaid benefit. PACE provides comprehensive medical and social services, including all Medicare and Medicaid covered services. And that uses an interdisciplinary care team of health professionals located at a PACE center. And PACE provides transportation to the PACE center and to other medical appointments. To be eligible for PACE, people need to be age 55 or older, live in the service area of a PACE organization, and require a nursing facility level of care, yet still be able to live safely in the community. When a person enrolls in PACE, the PACE organization essentially becomes their Medicare and Medicaid insurance provider. There have been many evaluations of PACE over the years that have found generally favorable effects on outcomes, including lower hospitalization rates, increased use of preventive care, decreased mortality, and improved participant satisfaction. Next slide. Of the over 150 PACE organizations operating in 32 states and the District of Columbia, a little over 15% are located in rural areas. And I know we had a few people submit questions in the registration asking if PACE was available in their location. So we'll linger here for just a second so you can find if there's a little dot on the map where you are. PACE has about 70,000 enrollees, who are approximately 85% are duly eligible for Medicare and Medicaid. Next slide. Because we're focusing today on how PACE can serve duly eligible individuals, I wanted to quickly remind you that there are over 12 million people in the US who qualify for both Medicare and Medicaid, and they are a diverse and high-need population. Many of them have chronic physical and mental health conditions and need long-term services and supports. Because Medicare and Medicaid were not designed to work together, duly eligible individuals tend to experience gaps, duplication, and fragmentation in their care. PACE addresses these challenges because it integrates and coordinates the Medicare and Medicaid programs' benefits, administrative features, and financing, which makes it particularly well-positioned to serve duly eligible individuals. Now, importantly, 21% of duly eligible people live in rural areas. That, as defined by the Office of Management and Budget, a rural area is where it's a non-metropolitan area of under 50,000 people. Next slide, please. So I'd like to welcome our presenters. First up will be Sean Sullivan, who is the president and CEO of Midland Care Connection, which is a nonprofit integrated community care organization. Midland provides care and services to more than 2,100 people across 28 counties in Kansas through PACE, hospice, home health, Meals on Wheels, and palliative care. Prior to coming to Midland, Sean served in executive roles in both long-term care and government, including a stint as the Secretary of the Kansas Department of Aging and Disability Services. And when he was in that position, Sean worked with the state's PACE programs and policy leaders to reduce barriers to access and expand markets served by PACE providers. Then we will hear from two state officials in Pennsylvania, Aaron Slabonic, who is the director for the Division of Integrated Care Programs in Pennsylvania's Department of Human Services Office of Long-Term Living, where she is responsible for the administration, operations, and oversight of the state's Living Independence for the Elderly, or LIFE program. And that is what PACE, Pennsylvania calls its PACE programs. And she also is over the state's dual eligible special needs plans. Erin has over 19 years of Medicaid managed care experience and has spent most of her career in various roles in Pennsylvania's medical assistance programs. Presenting with Erin is Randy Nolan, who is the director of the Bureau of Coordinated and Integrated Services in Pennsylvania's Office of Long-Term Living. And he is responsible for the management and oversight of the LIFE program, as well as the Community Health Choices program, which is the state's Medicaid long-term services and supports program. So with that, I will turn it over to you, Sean. Welcome.
Thank you, Nancy, and thank you to the Center for Healthcare Strategies and the foundations that help fund this. This is a very important and timely topic and subject. For me, it is one that is deeply personal to me. Part of that is I think we're all informed by our own personal professional experiences. For me, I grew up in a very rural area in small town Kansas, which to me, I know federal has a definition, as you said, of metro areas of 50,000 for less. How I define rural areas is how many stoplights they have and kind of the scope or scale to how many that includes. So for me, that was in a small town in Kansas that had a flashing light, and that was it. My family has roots in even more rural areas than that, what are considered frontier areas in Kansas. And then professionally, early on in my career, serving as a long-term care nursing home administrator, served in a couple of very rural places in Northwest and Central Kansas that were areas or towns of anywhere from 1,000 to 3,000 people. And then later, while serving in a state official public policy role, also cared very deeply about rural issues for those reasons. As it goes on PACE, when I was first in a state official role about 12 years ago is when I first heard this program. I would say it'd be accurate to describe me at the time as a PACE skeptic. And the reason for that was probably because of my long-term care nursing home background where I had come from. And at the time, there were 2 PACE programs here in Kansas, and the leaders came to us and were advocating for removing a number of barriers to the program here in our state. I was hesitant to do that, to have our staff do that, even though PACE, as we call them, participants, they're participants, not clients or participants. Thought PACE was cherry picking their clients or participants, and probably better options were available. However, we studied the system more, looked more at the profiles of who our PACE programs were serving, looked at their outcomes, and over a series of time became very much a believer in the program. As I said, I think personal experience tends to drive us. That's no different from me. I've had family members, lots of family members that have struggled to stay at home where they want to be in their communities and rural areas, and believe still now that if PACE were in those areas, they'd be able to more successfully age where they are and age in place in their homes. On the next slide gives a quick background as to who Midland Care is. So as Nancy said, we are an aging services provider that is primarily community-based. For the last 45 plus years, we've had a mission of addressing needs of older adults in the communities that we've served, and if necessary, have tried to start new programs and services to fulfill that mission. So that has led to be one of the first hospices in the country, starting in the late 70s, one of the first organizations to have a freestanding hospice, particularly in Kansas, and then also one of the first hospices, or the first hospice to start a PACE program 15 plus years ago. Today, we offer many service lines, but our largest one is PACE, and it's actually 80% of our revenue that we have coming in. We are a nonprofit at our core, and is who we are. On the next slide, to get a little bit more into our PACE program, to look at are we urban, metro, rural? Really, that answer is we're a combination of all those things. Today, we are serving nearly 600 PACE participants a day. We currently serve 12 counties. Most of those are rural, and we have 4 PACE centers. So the first PACE center we have is in Topeka. Topeka is not defined as a rural area. Topeka's county we're in has about 175,000 people in it. However, the 7 counties around Topeka that we serve through our center there are rural counties and serve anywhere from 4,000 to 15,000 in total. The second center we have is in Kansas City, which also is not rural. The third is in Lawrence, also not rural, but it is a college town, and there's only 300 what we call PACE eligibles in that particular county. And the fourth area that we serve is called Emporia, Kansas, also about 30,000 or so in that county. However, also a college town like Lawrence, and there's actually only about 150 people that are eligible for PACE, according to demographic data available in that particular county. When I started here a couple of years ago, I asked our leaders, why did Midland Care go to Emporia, go to Lyon County? It's really not big enough to have a standalone PACE program. Why are we adding a center here? And their response was one I should have thought about before asking the question, which was actually when you were Secretary of the State Unit on Aging several years ago, you added this particular county as a requirement for expansion for Midland. On the next slide, a little bit more about those markets. So generally, the standard for PACE organizations has long been kind of serve 10 to 15%, kind of 15% of number of people eligible in a county, you're doing well. And that tended to be the ceiling for the what we call the penetration or the saturation rate of the people we're serving. However, I would say probably since the pandemic 3+ years ago, it's been a lot more than that. So just we as one organization have grown 82% when I looked last since the pandemic began, just a PACE enrollment, so about 20% a year. So that 15% ceiling on the number of people we're serving has increased dramatically, particularly our Midland Care PACE rural markets. So as an example, in Lawrence, again, not a rural market, it's a college town, but take those part out of it, only 300 people in that county that are eligible for it. We're serving almost 30% of the number of people eligible for the program. In Emporia, only 150 people. We are as of today serving 73 out of that PACE center and PACE market, which is 49% of who is eligible. So that have kind of blown past that ceiling. On the next slide gives a brief history of PACE in Kansas. I'm going to skip over that for time, but there has been an intentional effort to try to expand PACE in our state to more rural areas for a variety of reasons, and also just to expand PACE as a whole to make it a more viable option in our range of community-based services. If you go to the next slide. One more. I would say with any state, whether rural, metro areas or not, there's kind of a combination of factors that drive whether PACE is a viable program and how successful it's going to be and how sustainable it's going to be. The first is how much is PACE allowed to grow in a state? Are new programs allowed to grow? Are current programs allowed to grow? Is there an enrollment cap in place? All those are important factors into the success and the viability of a program. On the next slide, the second thing generally is access to PACE. Questions such as who conducts level of care assessments? Is that conflict-free? Who's providing the counseling? What's that process, system, timeline like? Third, what's the sustainability? Are rates, particularly the state Medicaid rates, keeping up with what they need to be? And if not, what's the plan for addressing that? As if we as PACE providers and organizations do not have competitive PACE rates, are not able to hire the number of staff, have the type of programs and services that we need, we're not going to be successful, and the state's not going to want to continue to do that. The key factors of growth for our particular state on the next slide have been kind of 4 or 5 different things. The first is a commitment to growth in all areas, urban, suburban, and rural. And that really has been fueled by both legislative and state agency champions. The second has been ability to increase access through significant legislative change of what we call the protected income level. It used to be several years ago that our older adults that had qualified for PACE could only keep $717 of their income. And when even though PACE pays for and provides for most things, it doesn't pay for gas, it doesn't pay for utilities, it doesn't pay for rent, it doesn't pay for food. So if you have an older adult that's looking at, okay, I've got to pay for these things, even though PACE is paying for my medications, my doctor's appointments, my primary care, my inpatient care, all of that, often that kind of took PACE out of the equation as a legitimate option. Since then, that has changed to where it's currently around our older adults got to keep about $3,000 a month of their income as a protected income level. So that's been a significant welcome change. Enrollment caps have also been taken out, rate increases have been provided, and there's been a huge focus put on increasing awareness of the program. On the next slide, really is kind of what I wanted to spend most of my time on before turning it over to the state officials to talk. So the first is what we see, or what I see as a PACE provider as kind of the primary barriers to PACE programs being in rural areas and being able to do that. So the first is really just a low volume of potential people to serve. As Nancy described, PACE is responsible for the entire basket of services under the Medicaid, Medicare A, B, and D benefit. We get a capitated rate from Medicaid. We get a capitated rate from Medicare to cover that. We combine it. You're able to be flexible in how we spend that, provide an increased level of prevention, primary care, in-home support services, transportation, really just we're our own insurance provider. We're able to do whatever we need to keep that person at home, and that's what we're financially incentivized to do. But as a standalone organization, if you don't already have PACE, you really need 90 to 100 participants to spread out the financial risk of the inherent part of this, of the financial, the way it works financially. So if we have 2 people at the hospital today that are in inpatient stays at a hospital, or we paid $800,000 a couple months ago for a inpatient surgery for one of our clients in PACE. If you don't have enough participants to spread that risk around, then it makes it awfully hard to do. So that is a challenge to do in rural areas, just from the lack of volume of potential participants. The other major reason for that is you just really don't want your folks you're serving on a bus, van, or car sponsored by the PACE program for much longer than 30, 45, 60 minutes. So that's the other major challenge. The potential methods or ways to mitigate that. So one, existing providers such as Midland or others of the 150 that are out there now can serve rural areas from their more urban PACE centers. So we do a lot of that here at Midland. So using Topeka, Kansas as an example, we have our center in Topeka, Kansas, but we serve 7 rural counties, smaller counties, as a satellite kind of program from our Topeka center. Existing providers, number 2, I think, are able to serve a smaller number of people. So the 90 to 100 may not be the same baseline for existing PACE programs. As we have looked at this closely, we think we can successfully serve people with standalone PACE centers and new, more rural markets, serving about 60 to 70 people. We already are spreading our costs between the rest of the centers, and those fixed costs are spread out, which helps. And then third, to go into that, either for current PACE programs or new ones, our experience in rural markets have been, particularly in Emporia and in the rural counties we serve around Topeka, is that 15% penetration rate that used to be the standard is really not the standard anymore. So especially if there's a lack of other community-based services in that area, if you're able to serve 30, 40, 50% of 150 that are eligible, you can make that work. If it's 15% of 200 people eligible, that's a pretty difficult math equation. The second challenge is on the next slide, which are the service challenges related to rural PACE provision, which is distance to the center from rural areas and challenges for drive time of the staff and all that. One slide prior to that, if you could go back. So the ways that we have been able to mitigate that have been utilizing telehealth, remote patient monitoring services, contracting for local physician coverage, which CMS allows waivers for PACE programs to do now. They didn't used to do that. So we're able to serve rural areas from our urban hub, and then also in our standalone rural center. As we started those up, we have done that with local contracted community physicians. We also have contracted with local providers in both scenarios, either in rural markets served by our Topeka or Kansas City hub, and also in our standalone rural market centers that we have. The last one on here is development of an alternative care site, or ACS, is an option, allowable option by CMS. So ACS is a satellite center where not all PACE services are provided, but some are. So it could be a day center in a rural area, in a rural market, either contracting to somebody in that area to do that. It could be us doing it on our own. Those are kind of all options, or contracting certain things of those out. So I would say, just in general, with either current PACE programs or new PACE programs looking to serve rural areas, I think we often can let the perfect be the barrier to something good. So the perfect, to me or to most PACE providers, would be in this system where we have a fully aligned clinical and financial system, where PACE is in-house doing mostly everything, including physicians, primary care, therapy and home support, home health aid support, nursing support, transportation, et cetera. The PACE staff are meeting every day, every morning within their interdisciplinary team or IDT team to review hot issues and track care as needed. The reason we do that as a PACE model is so things that happen, like as drivers, when they're not within our transportation department, go and they pick up a participant and they notice an uneven floor, they notice the participant's gait has changed, or just something feels off. Same for home health aides. They can then feed that back to the larger team the next morning or that same day. And then our nurses and our providers that we employ then are following up on that and coordinating it. They're bringing them to the center, to the medical clinic that we have. All those things are getting done, and we're incentivized to provide an increased level of preventative care, primary care, instead of going to the ER hospital as a first course of treatment. So that is the perfect. In rural areas where we may be contracting out some of those things, it still can be very successful with the outcomes that can be achieved. So we may be contracting out the day services to an existing provider. We may be contracting or sharing a space with the senior center to provide day services in a rural area. But within the model, we're still coordinating care. We're still integrating contracted providers into our interdisciplinary team process. We're still ensuring transportation is provided, which is a huge gap. As our primary care provider, maybe on a contract basis, visits in rural areas, and it's not our providers that are doing that. Our pay staff, in-house staff that we employ are still ensuring the appropriate follow-up care is provided, the orders are followed. They're still evaluating polypharmacy issues. They're still ensuring medications are appropriately integrating with whatever that participant has going on. And the root of it is all that's because the financial incentive is for us to keep that person at home, out of the hospital, out of nursing homes. And that's how PACE programs are successful financially. And this also happens to be what the people that we serve want. So that I think is still, may not be perfect, but it's still pretty good. So on the next several slides are just more information on that. Other barriers are there sometimes can be a lack of buy-in in rural areas. We as a provider have run into that. I have run into that quite frequently. The PACE model runs contrary to what critical access models need to have for volume. So we've had critical access hospitals that haven't wanted to contract with us as in-network acute care hospitals or hospital systems because they want the heads in their beds to financially keep them viable. Same thing for physicians. So there's ways to mitigate that if able to think through that thoughtfully. And the last several slides going next are a little bit more information that you can go to later if you'd like, or go and find on the internet a group called the National Advisory Committee on Rural Health and Human Services, which is a lengthy acronym. They came to Midland Care to Kansas in the fall of 2022 to study rural PACE provision and the federal regulatory barriers or statutory barriers that are in place that could be addressed to make it a more viable service provision to rural areas. And there were 8 central recommendations that they made that are on the next couple of slides for how to best do that. So the one that I think is probably the most critical one is making PACE a more viable program for people that have Medicare as a coverage, but not Medicaid as a secondary payer, so they aren't dual eligible. So what that would do is it increase the pipeline of people in rural areas viable for a PACE program to serve, and would I think significantly increase the number of people or places where PACE could be. So again, I'm not going to go through those in detail, but that was a great exercise, and a lot of good recommendations went into that report. With that, I'll turn my camera off and
Thank you, Sean. Appreciate that great presentation. I'm sure there are going to be quite a few questions that folks will have, but let's turn now over to Aaron and Randy from Pennsylvania's Office of Long-Term Living.
Hello, good afternoon, everyone. My name is Erin Slabonic, and I am with the state of Pennsylvania, the Department of Human Services, Office of Long-Term Living, and we oversee the LIFE program, which stands for Living Independence for the Elderly. The reason we differentiate the name in Pennsylvania is because we have a pharmaceutical benefits program for older adults in Pennsylvania that is also the acronym PACE. So LIFE is how we differentiate that in PA. You can go to the next slide. I will say that when we were first approached to present on our rural strategies, we're a little bit taken aback as we are trying to expand and are struggling. But then when I do look at it, I think we've been We've been operating the LIFE program for so long, and we are expanded across the majority of our state, not even thinking that really a good portion of our state is already rural, and we are serving those rural areas. So we are able in our 54 county service area to serve over 90% of Pennsylvania's LIFE eligible population. So we still do have 13 rural counties that are not yet serviced by LIFE, and that only accounts for less than 10% of the LIFE eligible population in Pennsylvania. So, you know, we are serving over 90% of our state's eligible population, even with not being in those 13 counties. Just to give a look, you know, we have 19 LIFE providers across Pennsylvania. We have 57 LIFE centers and right about 7,900 participants. And just the numbers below just kind of show how we compare nationally, showing that we serve about 12% of the nation's PACE enrollment. You can see over to the right, just broke down sort of our population, our program by urban and rural counties. And this is by definition from the US Census. So that's basically how we're defining urban versus rural here. So as you can see, we do have, you know, 35 of our counties that we're currently serving are defined as rural. And then you can see in the 19 that are urban, you know, we have far more centers, alternative care sites, and obviously close to twice the amount of participants as well. And I know Nancy had mentioned, I think 21% of, you know, the population are dual eligible, and we have 26% of our Pennsylvania population, you know, living in one of its rural counties. And I will say too that to Sean's point, you know, he talked about defining rural by stoplights and stop signs. And I think that's probably our definition as well in Pennsylvania for the counties that we're currently serving that are rural. And then we sort of joke about these 13 additional rural counties as even more rural, in that you're probably more likely to run across, you know, a cow or some sort of wildlife than you are another person in those counties. So you can go to the next slide. So we did attempt to expand statewide last year at this time. December 3rd, we posted a notice in our Pennsylvania Bulletin, which is how we post opportunities to expand our LIFE program in Pennsylvania. So we were soliciting proposals for the expansion of LIFE services into those remaining 13 counties, and we received no response. So this is where we realized, okay, we have a challenge on our hands here. We had never run into this before really with other expansions. So we followed up with a survey to our existing LIFE providers to try to find out, you know, why didn't you bid? What were the challenges? Basically give us the reason so we can review that and try to work on it. We received responses from 75% of our providers, and the top three, kind of the most consistent responses across them, were that the rural counties with low population density that is very spread out makes business more difficult to sustain. The locations are not financially feasible given the current reimbursement and would require a higher reimbursement rate for rural areas. And just sort of those existing, the constant workforce challenges that remain everywhere. I think they came more prevalent during COVID, it seems, and never sort of got too much better after. Just some other known challenges. The bid and application process requires the providers to perform and submit full feasibility studies, which I know, you know, Sean had mentioned as well. And it's sort of, you know, how do you find that you're going to be feasible in some of these areas where there's a very small population And, you know, even when you think about it, just because you might know the eligible population in that area, not everyone's going to choose the PACE model. It's not a, you know, a fit for everyone. Additionally, we know that there's, you know, current CMS requirements and program policies that don't allow for some of the flexibilities that would be needed to implement some of the more innovative approaches to serving these rural areas. And when I say that, you know, I think of one of the more innovative things we think of is, you know, possibly having the ability to have an ACS or to contract with, you know, a current senior center, which would technically be an ACS, but then to also have, you know, maybe a mobile clinic that that could come into service these areas, being much lower cost than having that full build. But, you know, CMS requirements, there are physical location requirements that are required for these feasibility studies, for the readiness review process. So that's not really currently, you know, a possibility. As Sean had mentioned, the ACSs are, you know, a good alternative as well to supplement in these more rural areas. But again, with, you know, even the transportation with that, you still have to have a full center somewhere somewhat close by so that the participants aren't on these, you know, ridiculously long van rides and that sort of thing. So I think the challenges, you know, Sean spoke to most of the challenges, I feel like, in his section. So yeah, I think that's kind of where we're at in Pennsylvania. I think, you know, he also spoke to telehealth though, which is something that I think our life providers weren't necessarily utilizing prior to the pandemic. And I think, you know, if we can look at, you know, some positive takeaways, that would be one thing, is that realizing the benefits of telehealth and seeing how it can work in this model. You know, some of our providers, one of them issued with grand pads, so basically an iPad, but that doesn't need Wi-Fi, and they were able to interact with their participants. They were able to set up things like medication reminders. They were able to still have activities where they could connect participants with one another. They could still play, you know, word games or different, like, you know, online bingo kind of games, to bring that socialization to, you know, to the participants. So I think, you know, there are a lot of innovative ways to serving this population in this program. And I think in Pennsylvania, it's just a matter now of realizing, okay, we understand that we have these 13 counties we want to expand into. We want to offer PACE services statewide. So now it's going to be about working together with our providers to figure out, how do we make this work? And I can drop, I'm not sure if I'm able to at this point, to drop our website with our life program information in the chat. Am I able to do that?
Yes, so I think if you go into the chat, Erin, and pick everyone as their message recipient, you should just be able to drop that link in there, and people should be able to, I believe.
Hey, Erin, so if you send it in the chat, Nancy can copy and paste it out for you.
I got it.
I can do it. Awesome.
All right. Well, thank you so much, Erin, and Sean too. I want to invite another, well, not speaker, reactor, I guess. So Winter Roberts is also joining us today. She is from the state of Colorado, where she is the PACE compliance specialist for the state. And Colorado too also has many rural areas. And Winter, do you want to just come on and tell folks a little bit about some of the more innovative ways that the state of Colorado has been trying to foster PACE in rural counties?
Sure. So based on definition of rural, again, because it does change, we technically have one organization and two PACE centers that are located in what we classify as rural. We have a third that I would put into that category as well, because they have the same challenges that, you know, we've been discussing today. We don't have an active plan to grow our PACE centers into rural areas, although I do think that that's to come. Right now, we're focusing on developing state regulations for the PACE program within our state. And once those regulations are implemented, the expected date is mid-March of 2024. Then I think the state will begin to focus on where is most appropriate for our request for proposals. But what I can tell you is we're very lucky in our state, because back in 2021, we had a House bill that required some pretty swift action regarding broadband services. So that House bill was really successful because 93% of our rural areas have access to broadband. So the centers are able, like Erin was talking about, they're able to have those grand pads or similar devices and use that telehealth with their participants. And then regarding transportation, a similar issue that we've identified in our rural centers that's really successful is they have what they call a para plan. So they have an iPad. Each driver has an iPad with this system, and it gives the driver real-time access to the participant's record, the transportation manifest. So if the participant cancels, they're able to enter that information right into the system. IDT is able to start discussing, you know, what that participant may need, what the reason is for the cancellation, rescheduling, and such. So that's really good. The telehealth opportunities that we have, they're invaluable because, again, it's, you know, it's preventing that long trip to see a specialist, the potential overnight stays. And then regarding workforce shortages, I know that was a key theme, and our state has been very, very innovative, I think, and I can share some links to some of our pages, but we've strengthened our workforce in the, you know, the rural areas and looking at sustainability. Some of our initiatives directly impact PACE providers, like increasing their rates during the public health emergency, but many of our initiatives impacted PACE centers indirectly, and will continue to do that. So, for example, we created career development pathways for direct care workers, and we're researching ways right now to partner with hospitals and rural health clinics to identify opportunities to share and use more resources more efficiently. We have, coming in 2024, so first quarter of 2024, we have a direct care careers website that we're launching that will be available to PACE organizations as well as job seekers. And so this site will help to partner the employee with the employer. So that's exciting, more to come there. And then we just have a general direct care workforce collaborative. Excuse me one second. And that's improving our compensation and benefits for the direct care workforce. We're training and providing career advancement. And I think most importantly, too, we're just publicly recognizing the value of the direct care workforce, and including members of the direct care workforce into that collaborative, so that we can encourage more people to begin to take on this responsibility and this, you know, obviously we value their work, but not everyone works and understands the amount of work these folks do. So those are a couple things that we're doing here in Colorado.
Great, thank you so much. Really appreciate some really innovative and exciting sounding opportunities. So let me invite our panelists to come back on camera, and we will move into our Q&A portion here. And while folks are doing that, I see a couple of questions that have come in for you. So let me quickly ask these of you, Winter. Someone asked, is your direct care workforce inclusive of community health workers or other people with lived experience?
Definitely.
Okay, short and sweet, good answer. And also another one for you. Are those coordinating transportation mobility managers? Does that make sense to you?
Might need a little bit more. The PACE, I can say too, and I should have clarified that this is one of those indirect partnerships. So this is within our office and within our department, but it's not driven by the PACE unit. So if there are really direct questions like that, I'll provide the links to the programs, and then hopefully that can address the person's question.
Great, okay. So we received a number of questions both in the webinar registration, and we're getting them in live today. And thank you for that. We really appreciate it. I'm going to focus though, because they cover a wide range of topics. Not all of them are completely pertinent to the focus today. So I'm going to try and make sure that we stick to the topic of rural PACE today. I would say that we're going to share some links to resources at the end, and for folks that have more general questions about what PACE is, then I invite them to look at those resources. So I'm going to start probably with a question for you, Sean, that came in earlier, and that's very simply, do PACE programs get paid any differently for people who are the participants in rural areas? So for example, obviously your transportation costs are probably higher. Do you get paid any more for that?
So we get two capitated rates as provider. The first is for Medicare. On the Medicare side, the answer is no. On the Medicaid side, I believe there would be an option. So there's state Medicaid rate setting guidelines, and it's been a few minutes since I've looked at those, but I believe as long as the state is paying less than what's called the AWOP, which is an acronym for the amount otherwise would have paid for that comparable population, then they could adjust that geographically. So in Kansas, we get paid based on 3 different age ranges, and then geographical factor is factored into our rates. But there's really not much of a rural bump. So that probably is something we should talk more about as providers in the state. And that was something that the National Advisory, the long acronym that I mentioned earlier, when they came to study this issue last year, enhanced rates for rural providers was one thing that they did recommend.
Right, perfect. And while we're on the topic of financing, let me ask Aaron and Randy, the startup costs for PACE are pretty high. Are states thinking about any ways to be creative to help finance expansion into rural areas?
So I would say, like I said, we just surveyed our providers, kind of got those results back. We need to have internal discussions. We need to meet with our providers to discuss the different ways that would make it more feasible for them to go into these rural counties. An initiative that we're undergoing, though, in our state is the collection of encounter data, and also collecting just a new format for our quarterly financial reporting with the cost reports. So like cost reports, income statements, utilization. And we're going to be having our actuary review these reports as they come in now. And this is in an effort to really look at the cost, the utilization of the life program to see what type of reimbursement do they actually need. So, you know, historically, as Sean had just mentioned, the rule has kind of been the AWOP, the amount that would otherwise be paid. So we go by our managed long-term services and supports population in Pennsylvania to factor that amount currently. But to really look at life-specific rates and to start looking at those geographically, that's why we're pulling in this additional data to really get a better look and see, you know, what do the costs look like across the program from county to county, and how much does it differentiate based on geography. So that's something that we definitely plan to look at moving forward to see, you know, how can we maybe adjust the rates to factor those issues in.
Great, thank you. So Sean, in Winter's comments, she had talked a little bit about some of the flexibilities that were provided during the public health emergency. So what lessons did you learn from the public health emergency, particularly around telehealth? And how are you thinking about maybe incorporating those in the longer term, especially for the rural communities that you serve?
Yeah, that's a good question. I would say the pandemic taught the PACE provider world in general to be less day centric. So using our own metrics as an example, we probably had 50 to 70% of our PACE participants that were coming into the day center every day. And we provide transportation from door to door, chair to chair, from home to the PACE center. So more than half were coming in every day to the PACE center pre-pandemic. Since then, our attendance is more 20 to 25% coming in a day. So we do a lot more in-home support now. We do a lot more telehealth. We do a lot more remote patient monitoring systems. And it's not to say that we do all one or the other. We try to be thoughtful about this. So the initial assessments, initial appointments, significant issues are going to be done in person. They need to be done in person at the clinic, seen by our team. But to check up on someone, or just ongoing medical appointments between the providers and the participants, or just more minor things, and what we've learned is we can do that through telehealth, through the grand pads that were referenced, through other devices, and just makes it a lot easier to do and to carry out. So I think the ability to use telehealth and technology in general on a wide variety of things is one of the major lessons that was learned by most PACE organizations, or all PACE organizations, from the pandemic.
Great. Let's see. So for Aaron, there was a question about, and this was specific to Pennsylvania, whether Pennsylvania will require new PACE providers to contract with existing day health centers rather than potentially building their own centers, their own facilities.
So we wouldn't, historically in the past, we actually, all of our life providers were required to have their adult day license. That since that is no more, but we still do have some providers who have just chosen to keep it, as they do also run adult day programs. I don't see us as requiring something like that. That wasn't a requirement in the bulletin, but that would be, you know, contracting with an adult day center or contracting with any senior center, you know, even just leasing the space would be an example of an alternative care setting. So that would definitely be something that we would expect to see in a feasibility, you know, study that was submitted along with an application. But I don't see us requiring that as a specific, you know, you have to contract, it has to be an adult day center. Because I feel like that would be less flexible almost in an already challenging environment.
Yeah, I agree. So while you're off mute, let me ask you another question. In one of your slides, you had listed down that there are some CMS requirements and policies that are in your view, a hindrance to PACE expansion into rural areas. Could you just go into maybe one or two of what those requirements are?
So I think the major one I had already mentioned is just sort of those physical environment requirements to have that center, to have a PACE center, even if you do have the alternative care settings, which sort of puts the whole like mobile clinic idea, that just can't work with the current regs. I would say, and Sean had mentioned this too, just the struggle with, and this is across the board Medicare requirement, but the network adequacy, it gets harder and harder as you get into these rural areas to have an adequate network. And I think even more so sometimes for a new PACE provider who maybe the hospital system there isn't familiar with, isn't willing to network with. They already network with whatever insurer is in that area, and that's the only insurer they want to network with. So those are some of the challenges, and with that network adequacy, those standards also come in, the distance. So there is just that sort of unrealistic transportation in those areas. You don't want to put someone on a van or in a car for that amount of time, but it's in those areas, it's what's actually feasible. So
Got it. That's helpful. Thank you. So I think we have time for one question, and I'm gonna direct this one to Sean. And this actually kind of covers two things. So in the registration, someone had asked if PACE covers dental care, which it does. And then now we have a question in the Q&A asking how you handle those dental services, particularly in rural areas. Do you have the dental providers come to you? Do you send, what does your network look like?
It's different in every area. Finding providers willing to serve this population is extremely difficult, more so in some areas than others. We have a couple of ways we do things. One is we have a contracted vendor that comes into our PACE center and provides a clinic there, and we do it on a per member per month fixed cost charge to them on agreement. We also pay for our more rural areas. We will pay a rural provider in that area to be in network with us. And then we also have on occasion used more mobile services, which depends on the ambulatory ability of sometimes of a participant, but we've also used that on occasion. So vision and dental in particular, what we find when we bring participants on in our particular program, we enroll probably on average 15 to 20 new enrollees a month. Most of them have significant challenges around vision and dental and have not seen a provider for some time or even many years. So we often will have them seen right away, get what they need. But we do that through the combination of things that I mentioned.
Great. Thank you. So Emily, if we can please bring the slide deck back up. I wanted to share a few resources on the PACE program and also a link to the report that Sean referenced in his presentation. And again, this slide deck will be going out to all of you who attended today. If you can just move to the next slide, please. If you have developed evidence on what works when caring for older adults or adults with complex health and social needs, we would welcome you to submit your resources and ideas to the Better Care Playbook at the Playbook's website. And then finally, on our last slide, as a reminder, please fill out the evaluation survey that will show up on the screen. And we really value and appreciate your feedback. Thank you so much to our presenters today, Sean, Aaron, and Randy, and also Winter. We really appreciate it, and the support from the 7 Foundation Collaborative for making this webinar possible. And thank you for joining today and sharing your questions. Have a great afternoon.